Dear Chairman, dear colleagues, it is so a great pleasure to be here in this beautiful place. So I wish to thank Professor Enzo Bonora and the organizers for inviting me to share with you this perspective. I don't have any disclosure in relation to this talk because I'm not talking about diabetes drugs or devices. And it is long been known that chronic low-grade inflammation contributes to diabetes onset and complication. And this has been attributed to macrophages in the adipose, assuming a pro-inflammatory phenotype and driving some systemic metabolic changes. And in this talk, I would like to offer you an alternative view of how inflammation can contribute to the complications of diabetes. And this involves the bone marrow, hematopoiesis in a broader sense, and circulating stem cells. It all started many years ago when we made some strange, unexpected observation that in patients with diabetes or at risk for, there is a reduction in the number of stem cells in the blood. And this, if you look at the natural history of the disease, occurs early and persists over time. And this figure is about type 2 diabetes, but if we change to type 1, it's exactly the same. Unless there is a stronger effect of disease chronicity. The longer disease duration, the worse the number of stem cells in the blood of these type 1 young individuals. So what are these stem cells? We have to recognize that stem cells in the blood are for the vast majority hematopoietic stem cells, HSCs. And there are about 3 HSCs per microliter of blood. You remember that for each microliter of blood, white blood cell number is about 5 to 10,000. So it's a very rare population. And the other circulating stem cell types that are not hematopoietic are so rare, negligible numbers. Okay, so let's assume that most of them are hematopoietic stem cells. What happens in diabetes, this number goes down to about 2 cells per microliter. It's just a reduction of 1 cell per microliter. But it is so consistent and so reproducible in different studies, different countries, different laboratories, that we passed our years of research trying to understand what are the causes of this alteration, what are the consequences. So first we have to understand why hematopoietic stem cells circulate in the blood. The job of these cells is to make white blood cells and red blood cells, and they do their job in the bone marrow. So why do they need to circulate? Well, there are some hypotheses. First, these cells exit the bone marrow and traffic in and out to find better places. It's like finding a better parking for your car. Okay, you don't like the parking, you exit and then find another one. Because this is helpful, it's instrumental to maintain normal hematopoiesis, relocating at different bone marrow niches, hopefully where oxygen level is lower, and the stem cells keep them quiescent. Another function of the circulating stem cells is that the stem cells exit the marrow and enter peripheral tissues and organs, where they contribute to homeostasis, either by transdifferentiating into local cells, being them endothelial cells or even epithelial cells in the kidney, or by helping the tissue to repair itself by providing growth factors, cytokines, many other mechanisms, probably microRNA in vesicles, and so on. Finally, stem cells leave the marrow to reach secondary lymphoid organs like the spleens and the lymph nodes, where they perform so-called immune surveillance. So in diabetes, if there is a disturbance in the pool of circulating stem cells, all these functions can be affected. So what happens is that this leads to chronic inflammation, hematopoietic abnormalities, inability of tissue repair, and finally chronic complications. And to better understand the role of stem cells in maintaining the homeostasis of peripheral organs in the micro and macro circulation, we have to go back to the embryo and try to understand where the cells come from. in the embryo, hematopoietic stem cells come from the endothelium. They detach from the endothelium and move to the site where they install hematopoiesis. This so-called hematoendothelial overlap or hematoendothelial transition can be bidirectional and lasts even after birth to some extent, where hematopoietic stem and progenitor cells can to some extent differentiate into endothelial cells or endothelial-like cells. There is here a question mark because probably, as it happens for many things that changes from the embryo to postnatal life, this differentiation capacity is incomplete. But there is anyway the possibility that hematopoietic stem cells become endothelial cells or endothelial-like cells, and thereby being involved in the regulation of micro and macrovascular function. So the question is, why are the stem cells reduced in the blood of individuals with diabetes? There are at least 3 possible explanations. In the beginning, we only had access to the blood of the patients, and when we found something reduced in the blood, we thought there were 3 possibilities. First is that due to glucotoxicity and lipotoxicity, these cells were less able to survive in the blood where there is high glucose, high lipids, and so on. Second is that these cells simply left the blood to go into the tissues because there were ongoing tissue damage, so they were needed there to repair the tissues. And finally, there was the possibility that the pool of circulating stem cells was reduced just because it was not sufficiently replenished by the bone marrow through mobilization of the cells from the marrow to the peripheral blood. To cut a long story short, we developed strategies to check each of these 3 hypotheses, and we found that there is no major defect in the survival of the cells in the blood, and there is no excess homing of the cells from the blood to the peripheral tissue. So we were left with the core hypothesis that traces back to the central compartment where the cells reside normally, the bone marrow. So we already in 2006 had some clues that there was a defect in the mobilization of stem cells from the marrow to peripheral blood. We did some research in rats, and we found that when there was diabetes induced by streptozotocin, these animals were no longer able to release the cells from the marrow to the circulation in response to ischemia, tissue ischemia. But tissue ischemia is complex. It involves several crosstalks, different tissues and organs. So we want to check whether we could demonstrate directly that there was a defect in the bone marrow of diabetes. And we did studies in mice and then in humans by stimulating the bone marrow directly with a cytokine or growth factor, GCSF, granulocyte colony stimulation factor, that is normally used by hematologists to stimulate mobilization of stem cells and apheresis of stem cells for transplantation patients who have leukemia or lymphoma or myeloma. So by stimulating the bone marrow of these animals with or without diabetes directly with GCSF, we found that in the non-diabetic situation, there is normal striking increase in the number of stem cells in the blood after administering GCSF, and this is absolutely absent in animals with type 1 diabetes, type 1-like diabetes that induced by streptozotocin injection. And it is completely abolished. It is an on-off phenomenon. And look at here, it is exactly the same in human diabetes. These were patients with either type 1 or type 2 diabetes, and we found no differences. And we developed a test to check bone marrow responsiveness, called bone marrow reserve, by administering them with low-dose GCSF. Mind that these were patients without any leukemia, lymphoma, or hematologic disorder, just for a test. And we found that whereas non-diabetic individuals in one day are able to double the number of stem cells in their blood, this response is completely absent in individuals with diabetes. Again, on-off. It has to be something related to pathophysiology. But not only GCSF is able to stimulate the mobilization of these cells from the bone marrow to peripheral blood, but also tissue ischemia. It is myocardial infarction. What happens after myocardial infarction is that the ischemic tissue releases growth factors and cytokines. These cytokines, including GCSF, tell the bone marrow, look, I have an infarction. I need cells that helps me to repair. So the bone marrow releases hematopoietic stem cells. The hematopoietic stem cells migrate to the infarctor myocardium, and what is believed, at least from animal studies, is that these cells there help the tissue to repair, to reduce the scar, and to improve the function. What happens in diabetes? Not only GCSF-induced mobilization of the stem cells is impaired, but even after myocardial infarction, the mobilization of the stem cells in individuals with diabetes is reduced and is delayed. So again, it is so consistent and so reproducible in different settings that lead to a renowned hematologist to give this a name. And the name is diabetic stem cell mobilopathy. Oh, you can like it or not, but what we believe is this is another complication of diabetes that affects the bone marrow, another tissue that was not known to be affected by hyperglycemic damage. And in fact, it took us years to demonstrate what's going on within this tissue. So this is a normal histology or immune fluorescence of a bone marrow from a non-diabetic mouse. It is stained for the microvasculature in green, and from the innervation in red, because the bone marrow is innervated by sympathetic nervous fibers, autonomic nervous system. This is the histology of a femur of a mouse with type 2 diabetes induced by high-fat diet. It doesn't look so bad. But if you go into much detail, you will find microvascular rarefaction and distortion of the sinusoids. This is exactly microangiopathy that you can find in the kidney, in the retina, in the skin, in the lung, in the liver, in the placenta, whatever else. You find adipocyte accumulation and enlarger. This is nothing different than ectopic fat accumulation that we find in type 2 diabetes and also in type 1 diabetes. And there is arteriolar denervation, loss of sympathetic nerve fibers that normally cover the arterioles within the bone marrow. This is autonomic neuropathy. So the bone marrow is hit by high glucose, hyperglycemia, diabetes, and there you have microangiopathy, ectopic fat, and autonomic neuropathy. All these autonomic anatomic alterations could be sufficient to explain why the stem cells are not mobilized into the circulation, because they need the functional microvasculature for being mobilized, and they need a normally functioning nervous system. However, please note that the pool of stem cells within the bone marrow is not affected in diabetes. And indeed, diabetes is not associated with overt hematological changes with leukopenia or predisposition to leukemia or lymphoma. And in fact, when you look at the ability of these cells to be readily mobilized, this is done with a treatment that is different from GCSF. It is the desensitization of a chemokine receptor that keeps the cells attached to the bone marrow niche. If you use this drug, as it's called pladixafor, to desensitize the receptor, you can get a normal stem cell mobilization, even in individuals with diabetes. So this means that the number of cells that could be readily mobilized in diabetes is normal. So the defect is related to the response to GCSF and to tissue ischemia that, by the way, works through GCSF and other growth factors. So we wanted to explain why. Now we go back to inflammation. And I took advantage of this very nice paper published in Cell Metabolism a few years ago. This is just a cartoon. It starts from here, from hyperglycemia. And hyperglycemia has been found to induce the release by neutrophils of proteins like 6100 proteins or other DAMs, which signal within the bone marrow in the hematopoietic stem cell compartment and induces a skewing in the differentiation capacity of stem cells toward the myeloid as compared to the lymphoid lineage. So what happens is that these stem cells give rise to more myeloid progenitors and to less lymphoid progenitors. And this yields more monocytes, macrophages, and neutrophils, and less lymphocytes. This is the cause of the well-known imbalance in the ratio between neutrophils and lymphocytes in the circulation, which is well known to be associated with metabolic abnormalities and cardiovascular risk. But in the bone marrow that we have, induced by hyperglycemia, an excess number of macrophages. And what's the consequence of this excess number of macrophages in the bone marrow? Probably it has something to do with excess macrophages in the adipose as well. But we took advantage of a paper published some years earlier by the group of Paul Franette in New York, who found that some kind of macrophages, when they were increased in the bone marrow, they acted against stem cell mobilization. They were able to keep the stem cells attached to the niche. And to understand this, we have to look at the mechanisms that induce stem cell mobilization when a patient or an animal is treated with GGSF. GGSF acts in two ways, which are independent. First, it stimulates sympathetic nerve fibers. In turn, these fibers suppress niche cells, the nesting expressing niche cells, which are of mesenchymal origin. This suppression allows the cells to be mobilized because niche cells nourish the cells and keep them attached. When these cells are suppressed, stem cells are mobilized. The second pathway is that GGSF suppresses bone marrow macrophages. And this allows the stem cells to be mobilized because in a steady-state condition, macrophages keep the stem cells attached to the niche by producing a yet unknown factor which signals in the niche cells and induce a chemokine that keeps the cells in the niche. So with a couple of papers, we address these two pathways. And again here, I have the same cartoon to show you what happens in diabetes. So in diabetes, there is first autonomic neuropathy within the bone marrow, loss of these nerve fibers. So GGSF is no longer able to activate production of norepinephrine that allows the release of stem cells. Second, due to hyperglycemia, as I've shown you before, there is an excess in bone marrow macrophages. And these bone marrow macrophages are pro-inflammatory, and they produce an excess of what was an unknown factor. And now we have identified it is a cytokine called oncostatin M, which, by the way, is an interleukin-6 family member, classically pro-inflammatory family of cytokines. And these cytokines signal the niche cells to produce excess chemokines and keep the cells attached to the niche. So these are the reasons why GGSF is not able in diabetes to stimulate mobilization, while the resulting effect is retention of the cells within the bone marrow. So this is a more general cartoon of what happens trying to integrate inflammation and changes in stem cells. It starts from here. Again, high glucose. High glucose induces the skewing of the differentiation capacity of hematopoietic stem cells toward common myeloid progenitors. This gives rise to more myeloid cells, including neutrophils, monocytes, and macrophages. Macrophages in the bone marrow, when they are in excess, produce excess oncostatin M. Oncostatin M signal the niche cells that keep the hematopoietic stem cells in the bone marrow. And this is a vicious cycle because more hematopoietic stem cells in the bone marrow, more myeloid progenitors, more macrophage, and so on and so forth. And we've also understood which is the molecular pathway that drives the effects of oncostatin M on the niche cells. I'm not going into the details of this, but it is important that we understand something about the molecular pathway if we want to intervene in this pathway. But the consequences here are at the same time release of pro-inflammatory cells into the bloodstreams. That is, we have more pro-inflammatory monocytes and neutrophils in the blood of patients with diabetes. This is really reproducible. And the so-called mobilopathy, less stem cells that go out and replenish the circulating stem cell pool. While it is well known that excess white blood cells and imbalanced neutrophil to lymphocyte ratio is associated to cardiovascular complications, to kidney disease, and to many, many adverse outcomes, less was known of which are the consequences of this mobilopathy, of having less than normal number of stem cells in the blood. So we want to try to understand this. So we followed a cohort of type 2 diabetic patients, about almost 200, for about 4 years, and we divided them into two groups, those who had a higher than the median level of HSCs in the blood, as compared to those who had lower than median levels of HSCs in the blood. And you see here that those with lower levels had a strikingly higher incidence of new onset or worsening microangiopathy, being it nephropathy or retinopathy or neuropathy. So this works well as a biomarker, but we believe it is also an actor of the development of complications, and the patients who have lower number of HSCs perform worse in their risk of future microangiopathy. This was observed by following patients for just 4 years, but then we followed up them longer, you see here, up to 10 years, and then an association appears also with cardiovascular outcomes. So here, cardiovascular outcome is defined as 3-point MACE plus hospitalization for any cardiovascular cause, and again, the patients having a lower, below median level of circulating hematopoietic stem cells had a strikingly higher rate of adverse cardiovascular outcomes. So also for macroangiopathy, this biomarker performs very well in identifying patients at risk of future complications. So I'm going to conclude. When we started this journey 15 years ago, people were telling us or thought that the number of stem cells in the blood was close to zero, was basically zero. There has to be no stem cells in the blood because stem cells do their job in the marrow. So there was no interest at all in trying to understand why diabetic patients have less than zero, because there is no less than zero. Or in other terms, have a number of stem cells closer to zero. There was no interest until we demonstrated that this is a biomarker. This reminds me of the so-called Zeno paradox of the grain of millet, that states there is no part of the millet that does not make a sound. So the message is that each and every cell counts, just like each and every patient counts. And even in things that are very, very rare, there is a balance in nature, and disruption of this balance has negative consequences. So we spent our time trying to understand which are the causes and which are the consequences. Now, what we wish to do is to try to intervene in this pathological process. So what we don't know right now is that if we can move the patient from this group with low numbers of stem cells to this group with higher number of stem cells, the outcome of these patients will improve. So this is a big question mark yet, and this will be our challenge for the next years to come, maybe 15 years. So since I'm no longer working at the bench, I have to thank the people from the lab and also those involved in the clinical research, and also a word for Angelo, because 15 years ago, Angelo told me, Gianpaolo, I have this gut feeling. Look, this says, it seems to me they will be important. So I was 20, 24, 20-something, and I believed him like I believe in God, and I think I absolutely need to thank Angelo. Thank you.
Thank you very much, Gianpaolo. Beautiful presentation. is open for discussion.
Thank you. It's very interesting. Are the CD34 positive cells that come out in a patient with type 1 diabetes different than in normal? So if you looked at transcriptome, epigenetically, one might expect with a glucose effect that there may be some epigenetic changes. Have you had a chance to look at that?
Yeah, thank you. This is a question that we get very often because people say, okay, maybe it's not just a number. It is also the function that is important. And that is absolutely true because if you look at the ability of these cells to differentiate into endothelial cells or at least endothelial-like cells, it is impaired in diabetes as compared to normal controls. So again, yes, it is also a matter of function. But the most important function of these cells is to make blood. And in these terms, it is not affected, unless that it gets more myeloid cells and less lymphoid cells. But if you take these cells from a donor with diabetes and you try to transplant a receiver without diabetes or with diabetes, it doesn't matter, the effectiveness on the transplant is lower. So if you get leukemia and your donor is diabetes, you have a higher risk of dying after transplantation. So again, even for this function, there is something going wrong. Of course, what are the mechanisms? We don't know yet. Surely there is an effect of hyperglycemia. Probably there is an epigenetic reprogramming.
And just if I can ask another question. So prior to diabetes, and type 1 diabetes and the diabetes onset, there is this lower neutrophil count in the blood that has been reported by Manuela Battaglia and others. Comments there in relation to what you find after?
I have no chance to say whether this is in any way related to circulating stem cells. Nobody has never evaluated circulating stem cells in patients at risk for type 1 diabetes or very close to the onset, maybe before the onset, because otherwise there is hyperglycemia. So I don't know. But what I can tell you is that whereas in type 2 diabetes, the reduction in the cell number occurs very early. It is already there in pre-diabetes. In type 1 diabetes, it depends a lot on disease duration. Probably it is a damage that is accumulating within the bone marrow. Maybe in type 2 diabetes, ectopic fact is more important, which of course, before the onset of type 2 diabetes.
Any question?
Gianpaolo, this was very elegant and very much intriguing. Just a couple of simple questions. You mentioned several times that there is sort of an autonomic neuropathy that most likely affect the mobility of the stem cells. So the simple question is there any relationship with the classical diagnostic procedure for autonomic nerve function? And you also mentioned several times hyperglycemia, and also you implied that this could be a new form of complication of diabetes. So we tend to believe that correcting some of the mechanism or the culprit that generated the complication, we can bring the people back or to reduce the risk of complication. So rather than trying to re-establish the number of CD34 positive cells, what about in terms of preventing that? And what is the effect of improving metabolic control on this picture?
So first question is about autonomic neuropathy, and yes, there is a strong relationship between the normal cardiovascular autonomic tests that we do in the clinic, and indeed this was a chance finding in our lab because by chance we understood that the patients with the very, very lowest level of stem cells were those who had autonomic neuropathy. So it was a chance finding, then we understood that autonomic function is very important for the regulation of these cells. So that is, yes, a clinical readout. Second question is about the therapy or how to intervene. We can intervene by reducing glucose. In animals and in patients, it takes 6 months to 1 year for glucose control, for improve a good glucose control to translate into an increase in the number of these cells. So it is true that we can prevent it, but it takes time. Probably there is a regression of some anatomical phenomenon, maybe ectopic fat, something like that. Of course, it is reasonable to intervene on some of the pathways that are intracellularly induced by high glucose, some of them very well known. But there are other mechanisms that work exactly within this pathway, because in just 3 to 4 days with DPP-4 inhibition, you get a striking increase in the number of these cells. So there are several strategies that we want to check, we want to test, but it would be more important to understand the cause-effect relationship by trying to increase the number of the cells downstream of the effects of high glucose.
Great talk, Gianpaolo, Group Helsinki. It's intriguing they say you talk about autonomic neuropathy within the bone marrow. And I need to ask you, what would happen if you do physical exercise in terms of how you mobilize these cells? And the reason I'm asking this, because you talk about autonomic neuropathy, that could be organic or it could be functional. Because, just by having diabetes, you induce functional neuropathy that can be, you can change it if you do, for instance, intensive physical activity. So why haven't you tried to see what is the effect of physical activity for the mobilization of these cells?
Yes, we haven't, but other groups have done those studies, and they found that with exercise in general, you can increase the number of the cells. But the mechanism is complex, because in different populations of patients, they came out with different types of exercise that were able to increase the cell numbers. And it looks like exercise, the effect of exercise is mediated by tissue damage. There must be some tissue damage. For instance, in patients with coronary artery disease, you have to do exercise above the ischemic threshold to get the mobilization. So there are some studies with long-term improvement in physical fitness, look what happens, but not in diabetes. So not in the presence of functional or anatomic autonomic neuropathy. So we don't know whether exercise improving autonomic function would improve the level of these cells. But I think it is reasonable and worth testing.
Any other questions? Gianpaolo, you mentioned neuropathy, microangiopathy, fat cells. What about bone cells? I was thinking about the link between CKD and abnormality in the bone cytokine which are released. Are they affecting mobilopathy?
Well, this is intriguing because basically the osteoblasts here in the stroma of the marrow behave like the niche cells because they provide clues by secreting molecules and niche factors like osteopontin, osteonectin to the stem cells. So it is possible that the changes that are ongoing in the more specific bone lining of the marrow are themselves related to changes in the traffic of stem cells in and out the bone marrow. We don't have data so far. It's not easy, but in the preclinical stage, there are a lot of studies in the hematology field suggesting that if you modulate genetically bone formation and bone resorption balance, this is associated at least transiently with a release of stem cells into the blood. And this, on the long run, may be associated with a depletion of stem cells in the blood, leading to myelofibrosis. So my answer is that in diabetes and in DKD, I don't know whether there is a relationship between bone alteration and these stem cell levels, but in general, it is reasonable, and I think it can affect the number of stem cells.
Thank you, Gianpaolo. Outstanding talk. If you try to find a common denominator between micro and macro angiopathy, maybe one mechanism could be fibrosis. And the JAK-STAT pathway has been recently pointed out as the main pathway involved in this process.
So
have you checked the CD34 cells for this pathway?
It looks like you're smarter than me, because JAK stands here, exactly here in the middle. It is what translates the signal of oncostatin M. So oncostatin M is a fibrogenic molecule of the interleukin-6 family, and it induces CXCL12 exactly through the JAK-STAT pathway. So maybe JAK inhibitors will be helpful to intervene in this pathway.
Congratulations for this beautiful lecture. I have a question. How variable is the number of these cells in healthy people, and which are the factors which modulate mobilization of these cells from the bone marrow?
Yeah, there is relatively high variability, even within normal individuals. And I understood this when I did a control myself, and I found very low levels. So I was afraid of what that could mean for me. But then we understood, and we published about 10 years ago, that young men have lower number of stem cells in the blood than young women, because the cycling estrogens recruit stem cells to the endometrium to repair the endometrium. And in fact, Piero, uncycling anovulatory women do not have this increase in the numbers of stem cells. This is just, an anecdote, and it does tell us just something about the reason of the variability in normal individuals. So age, sex, reproductive status, physical fitness, smoking, of course, other risk factors. There are many, many others. But there is indeed a range of normality.
Any other question? I will ask you a very last question. If I remember well, DPP4 is also affecting this chemokine. Do you have any data on DPP4 inhibitors?
Yes, exactly. DPP4 has many, many targets. One of these targets is CXCL12. We can hear CXCL12 keep the cells in the marrow. So if you inhibit DPP4 in the circulation, this means that the gradient of CXCL12 leads the stem cells to leave the marrow and enter the circulation. So I was saying that with just 4 days of treatment with a DPP4 inhibitor, there is an increase in the number of stem cells in the blood. We don't know how long this maintains, because there are adaptations that would probably re-establish the steady state, but it's very fast. So this means that we can intervene in the very specific molecular mechanisms that regulate this process.
No other question? I will ask you another question, the last one, I promise. There is an interaction between the RAGE receptor and the AT1 receptor. They form heterodimer. Did you test the effect of RAS on the imbalance within the bone marrow between monocytes and the lymphocytes?
No, we didn't test them, and I'm really sorry, I don't have any idea what could happen.
Okay. Last question.
What about obesity?
Yeah, what about obesity? That's a good question, because I skipped some slides, but it can be quite similar in that here you don't put high glucose, but you put probably interleukin-6 or TNF-alpha, and these feed-forward mechanisms would go on basically the same. But probably there are stages of obesity wherein the number of stem cells in the blood is increased rather than being decreased. This has been demonstrated that in obese people, especially in the stage where they increase weight, the stem cells move out of the bone marrow to reach the adipose, the spleen, and other secondary lymphoid organs, and there they can even establish ectopic hematopoiesis. There are data suggesting, at least in mice, but also some data with human adipose tissue biopsies, that the macrophages generated in the adipose is that because in the adipose there are hematopoietic stem cells. So it's ectopic hematopoiesis in the bone marrow. But finally, later on, there is inflammation, and this inflammation fuels these feed-forward mechanisms, and in the end, reduces the number of stem cells.
But is the general distribution of adipose tissue, or is the ectopic fat in the marrow?
No, it is general. So the stem cells reach the orthotopic visceral adipose.
In terms of the negative impact of obesity, how much is due to the, let's say, the generation of the overall inflammation, and how much is the local accumulation of adipose tissue in the bone marrow?
Yeah, good questions. Actually, we don't know. It's not easy because there is an elegant study published in Nature Medicine a few years ago where they used a genetically modified mouse that enabled the investigators to instantly get rid of adipocytes, and they found this was the way they found that bone marrow adipocytes play a role in the bone marrow niche, but they were probably unaware of the fact that they were getting rid also of adipocytes in other tissues. And so this is like a model of lipodystrophy, okay, that has lots of metabolic consequences. So it is very, very hard to dissect the role of ectopic versus orthotopic adipocytes in the adipose.
Very last question.
Thank you for the talk. Does insulin have a role on the stem cell function or mobilization? For example, low insulin can increase mobilization, or high level of insulin or insulin resistance?
Well, I can tell you what I think, but I don't have data. I think that it has to be a role. In the niche, some of these stromal cells express the insulin receptor. They also express the leptin receptor, which is very important. However, when we checked the data, we never found any association with insulin levels, and we found an association between the number of stem cells in the blood and insulin resistance, but not between insulin or insulin resistance and the mobilization capacity from the marrow to the peripheral blood. In other terms, even in patients with type 1 diabetes, there is this defect. That is why we concentrated on hyperglycemia as a common denominator. But in general terms, I think that insulin has to have a role because the insulin IGF receptor during hematopoiesis in the embryo and the fetus is very, very important.